Good morning, everyone, and welcome to our webinar. We will be starting promptly at 10 Central, 11 Eastern. Thank you. Good morning, everyone, and welcome to the webinar. We're going to be getting started here in just a couple of minutes. Thank you. Well, good morning, everyone. It looks like we are right at 10 o'clock Central Time and 11 o'clock Eastern Time and are ready to start our webinar. We want to wish you all a good morning, and we really welcome you to this very timely webinar hosted by the P-TECH and Q-TECH networks, which includes Alliance Chicago, Health Choice Network, and the Illinois Primary Healthcare Association. My name is Nita Mohanty, and I'll be facilitating our session today. And as many of you are aware, scientific evidence shows that self-measured blood pressure monitoring, along with the right clinical support, can help patients manage their blood pressure. With the rapid adoption of telehealth during the public health emergency, we recognize the need to effectively engage both patients and care teams in best practices and to relate home blood pressure monitoring to existing quality measures. Today, we look forward to hearing from experts from the American Medical Association on these topics, and we're grateful that you're here to join us today. We're going to do a brief walkthrough of our agenda. To start, we'll start off with some housekeeping and logistics. We'll review our learning objectives. And since we all want to learn from each other, we've integrated some interactive polling questions, and we'll walk you through that technology. We'll then advance to our main event and presentation from the AMA, and finally, we'll end with the question and answer session. So to go through some housekeeping and logistics, you're currently in the session in listen-only mode. We do want you to use the question panel to pose any questions to our speakers, as this will inform the content of our Q&A session. And we will be recording this presentation and we'll be sharing it afterwards. And once again, we thank you so much for participating. So to review our objectives, today our speakers are going to do an overview of self-measured blood pressure monitoring. We will be discussing the validated technologies to support self-measured blood pressure. And finally, we'll review the most recent updates to quality measures related to self-measured blood pressure. And with that, I'm going to turn things over to Stephanie to walk us through the polling technology, and then we'll get started with our first polling question.
Hello, everyone. Good afternoon or good morning. Thank you for joining us today. So on the slide you see on your screen, we have some instructions for how to participate in today's live polling. To participate, you will be using your mobile phone. So if you take out your mobile device, you're going to send a text message to the number 22333, and the message being COVID-19 Heroes, as you see on the screen on the left-hand side. Once you send COVID-19 Heroes to that message of 22333, you should get a response confirming that you've joined today's session for the interactive polling segments. Once you receive that confirmation, then you're ready to participate in our live polling session, and you will just simply have to enter the selection in your message line to submit your answers. As an example, A or B for yes or no, as the slide indicates in the presentation. So I'll give everyone just a couple seconds to get confirmation on their phone that they're a part of the message group before we can jump to our first slide.
Right, wonderful, and thank you so much for that, Stephanie. And let's now try out our first polling question. So our first question to all of you is, are you incorporating self-measured blood pressure monitoring workflows for your patients? Please respond yes or no. We look forward to hearing from you, so we're going to give folks a couple more seconds to put in their responses of if you are currently incorporating self-measured blood pressure monitoring workflow for your patients. If you're having any difficulties using the chat, oh, perfect, there we go. Thank you. It looks like 60% are and 40% are not. Well, we really appreciate your response, and we'll look forward to other responses from you with the remaining polling questions we have throughout the presentation. So thank you so much. Well, with no further ado, I'm very excited to introduce our speakers today for our presentation. Dr. Michael Raycott is the Vice President of Health Outcomes at the American Medical Association. Dr. Neha Sachdev is the Director of Health System Relationships. And Ms. Linda Murakami is the Senior Program Manager of Practice Facilitation. Mike, Neha, and Linda, we are so very excited to have you here today, and we look forward to your talk, and we'll turn things over to you now.
Great. Thank you so much, Dr. Mahanti. So again, just to quickly introduce myself, I'm Neha Sachdev and the Director of Health Systems Relationships. I'm also a family physician by background, and I'm joined by my two colleagues, Dr. Ray Kotz and Linda Murakami, and they'll each introduce themselves further as we go. And as Dr. Mohanty mentioned, we've seen a lot of change this year, including a rapid rise in the use of telemedicine and digital health tools, and an increased focus in caring for patients outside of clinical settings. And looking at that initial polling question, some of you are already using out-of-office measurement, and for patients with high blood pressure, out-of-office measurement, specifically self-measured blood pressure, can be used for both diagnosis and management. So we're excited to talk with you today about some considerations for implementation. This slide has our objectives for today. Dr. Mohanty already reviewed these, and we'll cover these in the next 30 minutes or so that we have plenty of time for questions and discussion at the end, and we invite you to put questions in at any point. Next slide. So just to give some quick background on our work related to blood pressure at the AMA, our mission is to improve the art and science of medicine and promote the betterment of public health. And we're leading the charge to prevent chronic disease and confront public health crises. And the group we're all part of, Improving Health Outcomes, has set two specific goals of no new preventable cases of type 2 diabetes, and everyone with hypertension has their blood pressure at goal. And self-measured blood pressure can help patients with hypertension achieve and maintain blood pressure goals. So let's first start by defining it. Next slide. An SMVP refers to blood pressure measurements obtained by the patient outside of a clinical setting. And this includes blood pressure measurements taken by the patient while in their home. And we know there is a natural variability in blood pressure and that it fluctuates constantly in most people. Self-measured blood pressure can provide a more accurate and representative picture of a person's true blood pressure, as it involves taking multiple measurements for multiple days in an environment where a person spends a significant amount of time. And compared to a single conventional office blood pressure measurement, SMVP measurements taken over a week are much more predictive of future cardiovascular risk. Next slide. And it is practical and feasible to use SMVP in primary care. You can use SMVP for patients both with and without a diagnosis of hypertension. So for patients without a diagnosis, you can compare in and out of office measurements in order to make a diagnosis and confirm a diagnosis. So for example, if you have high blood pressures in office, but your blood pressures are not high outside of the office, you can confirm a diagnosis of white coat hypertension. And the reverse can be true, where blood pressures may be high out of office and not in office, and this is called masked hypertension. Up to a third of patients can have white coat or masked hypertension. So when you have out of office measurement to compare to in-office blood pressures, you can compare and properly diagnose patients with these BP phenotypes. For patients who already have a diagnosis of hypertension, you can assess blood pressure control and effectiveness of changes in treatment using SMVP. And you can use SMVP before or after a scheduled encounter, whether it's virtual or in person, and after a medication or treatment change, or at any point that you'd like to have more information about a person's blood pressure. And SMVP is often implemented with a team-based approach. The roles and activities performed by each team member will vary with each organization, but for example, providers will often take the lead on interpreting measurements, prescribing medications, and making the diagnosis or assessment of control. Other team members can provide patient training and education, communicate with patients about SMVP results and follow-up plans, And the patient themselves is obviously central to SMVP, and it's a great way to engage patients in self-management of their blood pressure. The last point about SMVP is that it is more effective when used with clinical support and co-interventions, and I'll touch more on that in a minute. Next slide. So guidance for SMVP and out-of-office measurement of blood pressure has been included in scientific statements and papers for years, both in the United States and internationally. So while there are new resources and technologies available now, the use of SMVP is not new. And this list just shows some examples of papers and guidelines that have SMVP guidance. The last paper noted here, the 2020 policy statement from the American Heart Association and the AMA, was released earlier this year, and it's a great resource to read more about SMVP. Next slide. So I'm going to turn it over to Linda in a minute to discuss steps for using SMVP, but I want to revisit the impact of co-interventions and support. When SMVP has been used with co-interventions like phone support, counseling, and education, a clinically significant reduction in blood pressure has been seen compared to usual care. And when accompanied by patient feedback, counseling, and adherence strategies, SMVP has been associated with an improvement in blood pressure control. So as you're considering implementation, it's helpful to also consider and implement co-interventions and support along with SMVP. And now I'm going to hand it over to Linda to discuss steps for using SMVP.
Hey, thank you, Neha. And I will, I'm Linda Murakami. Let me introduce myself. I'm a registered nurse and the Senior Program Manager for Quality and Practice Facilitation. And our team works with health systems on improving health outcomes, like hypertension control and preventing type 2 diabetes. So I'll be reviewing the 7 steps for self-measured blood pressure that our team at the AMA developed early this year. And I'll see if someone can post the link to the website in the chat, and I have a slide with the web address coming up as well. Next slide, please. So most of these steps have corresponding tools and resources to help guide you through this SMVP process. So I'll be sure to highlight those along the way. And so let me run through this list here, and then I'll follow with more detail. So the first step is to identify patients who are appropriate for SMVP. Then it's important to work with the patient to confirm they have a validated device with the appropriately sized cuff. After that, train the patient on how to perform SMVP and then have them perform those self-measurements over the course of a week. The patient will then return those readings to your care team, who should then average and interpret the results. And lastly, they should create and document a care plan and communicate the plan to the patient. Next slide, please. So step 1 is to identify patients for self-measured blood pressure monitoring. And both patients with and without an existing diagnosis can benefit from SMVP. So for the patients with an existing diagnosis of hypertension in this population, SMVP can be used to evaluate the effectiveness of treatment. So for instance, if a patient recently started new antihypertensive medications or had their dosage increased, SMVP should be used 2 to 4 weeks after to assess whether or not that change has been effective in lowering their blood pressure. And once a patient's blood pressure is controlled, providers may want them to self-measure before visits and periodically between visits just to ensure they remain controlled. And for patients without a diagnosis of hypertension, the ACC/AHA 2017 hypertension guidelines, it recommends confirming a diagnosis of hypertension with out-of-office blood pressure readings. So SMVP is considered an accessible and reliable method to confirm a diagnosis of hypertension in conjunction with in-office blood pressure results. So additionally, it can be used to identify patients who have white coat or masked hypertension, and SMVP can be used for patients with known labile hypertension or for any other patients whose BP you need to monitor more closely. Next slide, please. So the next step is confirming that they have a validated device with an appropriately sized cuff. So whenever possible, patients should use an automated, validated upper arm cuff to self-measure their blood pressure. And what that means is the device should be automated, meaning it self-inflates with the push of a button and doesn't require the patient to manually inflate the cuff. And the device should be validated, meaning it was tested for clinical accuracy by independent, skilled blood pressure measurement experts using one of the internationally accepted testing protocols. And Dr. Ray Katz is going to touch on where to find validated devices in a bit. So we also need the patient to use an appropriately sized upper arm cuff. Ideally, the patient's upper arm circumference should be measured to determine cuff size. But there's more detailed information on how to do this on that website. Wrist cuffs should only be used in instances where a patient cannot fit into an upper arm cuff or where medically required. There's a higher likelihood of errors associated with incorrect positioning on wrist cuffs. So if a patient must use a wrist cuff, they should be trained to properly position themselves to take the reading. So to help with this training, we also have a patient infographic on using wrist cuffs on the website. Additionally, a device that can store Too soon, thanks. Additionally, a device can store 30 or more readings is preferred, so the readings can be reviewed by the care team directly. And if using the memory from the device, advise the patient not to share that blood pressure monitor with anyone else during that measurement period. Okay, next slide now. Thank you. Okay, so step 3 is to train the patients how to self-measure. So this blue graphic here is a great tool to use while training patients on SMVP. Most patients have it with them and use it as a reference while performing SMVP at home and taking their measurements, like they'll hang it up in their kitchen or wherever they're going to sit. And it explains to the patient how to properly prepare them, position themselves, and then how to measure. So in order to properly prepare for self-measurement, we train patients to avoid caffeine, tobacco, exercise for 30 minutes before. And if they recently ate, they should wait 30 minutes before or after that meal. And patients should also have an empty bladder and perform SMVP before taking antihypertensive medications. So patients should find a quiet place where they can rest comfortably and be uninterrupted. Teaching the patient proper positioning includes placing the cuff over bare skin on the upper arm, having the patient sit in a chair with their back supported, lungs uncrossed and their feet flat on the floor, or use a step stool if needed. And their arm should be supported on a table or an armrest with their palm facing up. With the middle of the cuff, that should be at heart level. And patients should rest for 5 minutes before starting the measurements. There should be no distractions during the measurements. So that means no TV, no texting, and no talking. And patients should be informed on how to record their readings and share them back with the care team. They should also be told what to do if their blood pressure is too high or too low, or if they experience symptoms. So, and always be sure to confirm what the patient learned during training. So use something like teach back to have the patient verbalize, the process, or return demonstrate, what they need to do. And this training graphic shown on the slide also comes in Spanish. And we have patient training video, which is 3 to 4 minutes long and also available in English and Spanish. So next slide, please. So after patient training is complete, step 4 is to have the patient perform SMVP. So patients should take 2 sets of measurements twice a day, 1 set in the morning and 1 set in the evening, or when they wake up and before bed. Each set consists of 2 measurements, perform 1 minute apart. So in the morning, the patient would take a measurement, wait a minute, and take a second measurement, and then repeat the same thing in the evening or before bed. And happily, we want this to be done for 7 days, but we need a minimum of 3 days of readings, or 12, an equivalent of 12 readings being required to use this information for medical decision making. And again, a plan should be made with the patient on how and when they will share the measurements with their care team. Some patients capture each reading on a paper log and call them into the office. Others might bring the readings into their next appointment or share them via the patient portal. Devices brought in to the office with the memory storage, you can then scroll through and review the readings. And then some devices have Bluetooth, and that can allow the patient to transmit the readings to the care team, usually using a mobile app. The key here is making sure the patient gets you their results, because that's what Dr. Sajda was mentioning, making sure that we treat with these results, and that's where the effective control rate can improve. So the AMA, like I said, also we have that paper log to document their readings over the week. And there's areas on that log where you can customize the guidance. And so you can actually tell them what to do for those readings if they're too high or too low, or note, what there's too high a blood pressure for them or too low a blood pressure and when they should contact the office for help. Next slide, please. So after the patient completes their readings and shares them with the care team, step 5 is for the care team to average the readings that they receive from the patient into a single systolic and a single diastolic value. So remember that this should only be done if the patient met or exceeded the minimum requirement of 3 days or 12 readings. And if less were provided, these readings shouldn't be used for clinical decision making. Once the average is calculated, it should be documented in the EHR, and the provider should be notified that the SMVP information was received. So for step 6, the provider should review and interpret the average and make a plan of care based on that average. And there's an interpretation table available on the website to assist the providers with results. Next slide, please. And lastly, step 7 is to document the plan and communicate it with the patient. Closing this communication loop again, between the patient and the clinical teams, an important piece of self-measured blood pressure monitoring. And again, you should use TeachBack to confirm the patient's understanding and agreement to the plan of care. Next slide, please. So this was my overview on the 7 steps that you can use to implement SMVP. The link is listed here for accessing the resource. And the website, like I said, has all the tools I mentioned available for download. And I know I discussed kind of a lot of material in a very short period of time. So be sure to check out the website and do a review. And now I'll pass it over to Mike.
All right, great. Thank you, Linda. So my name is Mike Raycotts. I am also a trained family physician. I was in practice for 20 years before coming to the AMA 6 years ago, where I am the Vice President of Health Outcomes overseeing our clinical teams. Next slide, please. So I want to talk a little bit about using technology for self-measured blood pressure monitoring, and the 3 critical factors that I've outlined here that we're going to talk about are the importance of using a validated device, a device that is validated for clinical accuracy, which I'll go into in a little bit more detail, using evidence-based or guideline-driven patient education and user instructions. This is also extremely important if you want home blood pressure monitoring or SMVP to be effective at lowering blood pressure, which we all do. And we'll talk about how the data flows. We'll talk about access and use of data of these blood pressures. And you're going to hear for the 3rd time about the importance of closing that data loop, getting the data from the patient's self-measured blood pressures back to the care team so that you can act on it to actually improve blood pressure control. Next slide, please. So let's talk a little bit about validated devices. I think most people are initially surprised to learn that a majority of devices that are sold in the United States have not actually been tested for clinical accuracy. The FDA clears devices based on a process that doesn't require that because of there's technically a loophole there. So we wanted to create a list of devices where patients could go, pharmacists could go, physicians, care teams, anyone could go to find out whether or not a device that they're looking up or trying to use has been tested to make sure that it can give you an accurate reading. So in April, the US validated blood pressure measurement device list went up in the United States. And it's the first listing of its kind here, although these validated device lists occur in other countries and have occurred in other countries, Canada, Australia, Europe, the UK, for years and years and years. And they're extremely helpful in helping identify blood pressure measurement devices that take accurate measurements. And the validation process typically is using, having an independent expert at blood pressure measurement use an international validation protocol that usually tests about 85 people using mercury as the standard for measuring blood pressure in 2 people blinded. So it's a very rigorous process. Typically, the results are published in a journal, in a peer-reviewed journal, but that's not necessarily a requirement as long as the protocol is held up. So this is how accurate BP measurement devices are identified. We've listed currently 16 in our first iteration of this listing. We're going to expand that in the next month or so. And just realize that all of the devices on that list have been tested and are accurate. but not all devices that are validated are on the list yet. So we need the manufacturers to submit the data to get the devices on the list. So while we're waiting, the list isn't a complete list of validated devices. So don't think that just because something isn't listed on the US VDL that the device isn't accurate, but we've listed here 3 other international validated device lists where you can look up many devices that aren't yet covered on the US list. And that's why these links are here. You'll be able to access them, and they're quite good. Next slide, please. So let's talk about the second component, is guideline-driven, or again, evidence-based patient education. So for SMVP to be effective, you heard Linda say, it needs to be, and guidelines have recommended this for years, the education for patients needs to be formed by a healthcare professional. And this is because there's a lot of ways self-measured blood pressure monitoring can go wrong or become inaccurate quickly if there isn't proper patient preparation, which Linda reviewed, positioning, which she also reviewed. And then there's the actual measurement itself, the importance of using an evidence-based measurement protocol. So 2 blood pressures in the morning, 2 blood pressures the evening for a week. People do not need to do this indefinitely. It typically needs to be done a week prior to an encounter, whether it's a virtual or in-person encounter, so that you could effectively assess blood pressure control. This is just a sample of what one of our paper logs looks like that you can download. But not only does it serve as a backup for the device, but it also actually illustrates the timing for when blood pressure should occur and how they should be averaged. Next slide, please. So this is just a little bit of a process flow for what the options are for clinical teams to access and manage SMVP data or SMVP results. And just moving from left to right, we need some kind of signal to the care team that the person needs to go purchase a device or have a device loaned, and the clinical team needs to train them how to use it. The patient then performs SMVP, and the critical component, again, closing that data loop, sharing the blood pressures back to the care team so that action can be taken to manage their blood pressure. Prior to that, the results need to be averaged so that they can be interpreted in a way that is representative of the person's true blood pressure and predict future cardiovascular outcomes and risk. That blood pressure is the one that needs to be managed using the average systolic and diastolic. And that blood pressure should also be documented into the medical record for clinical decision making. And just to break this down a little further, so if we go back, when I said SMVP, it can be ordered. If you have an order in your EHR to signal that the process has begun, that could signal the care team, potentially for CPT coding options, depends on what you're planning on doing here. But you just need to create a process flow that makes it easy for the team to understand how the process gets started. It could be verbal as well, between a provider and a care team member. And the patient and education and training, again, we've reviewed that. Then the patient needs to perform SMVP in that evidence-based fashion, the way we described with all the prep and positioning. The device itself should be a device that can store at least 30 blood pressure measurements. Sometimes that's exceeded without people erasing it, so having a paper log backup is a good idea. The blood pressure measurements are then typically transferred to a mobile app. Sometimes they can be directly sent to an EHR, but typically it's a mobile app where they're then relayed to a cloud-based portal, or they can be messaged via secure email or SMS messaging to a member of the care team or the provider. But these are the things you need to think about on workflow. How do you want them to happen? Many manufacturers have mobile applications available for free. Then there are a host of those that cost money to do this, to create that cloud-based system. So data storage, again, can be done on the device itself. You can use a paper log, you can use a mobile app, or you can use a cloud-based storage if the device is Wi-Fi or cellular enabled. So patient sharing the results with the clinical team. This is a little bit of a double-edged sword. You hear all the time, we hear constantly that everybody wants these blood pressures coming directly into the EHR, either via a mobile app or via the device directly through the portal. But something to think about, because this is sort of an unanswered question, what the preference is. We'd love it for all of the blood pressures to come directly into the EHR so that we could view them. The problem is, if you're taking 2 blood pressures in the morning and 2 blood pressures in the evening, over the course of a 7-day period, that's up to 28 blood pressures. When do you want them sent to the EHR? How do you want them to be averaged and received, who will be taking care of that, and then communicating those results. So that's one school of thought, is to get the data directly into the EHR. The other is to put it up on a portal where, at the convenience of a care team member in their day, in their workflow, they could view, a case manager, an MA, and RN can view those results on a platform, typically a cloud-based platform, where they can review a population and do panel management. So that's just something to think about. You know, again, there's mobile apps that do secure email and text messaging, but the patient sharing the results with the clinical team is the most critical component, because without that, you're not going to see improvement in blood pressure control. You're not going to see titration of treatment and medications to lower blood pressure. Again, just to emphasize the importance of the SMVP results being averaged, that's something that can be done manually by the patient, but you try to avoid that whenever possible. You'd love it if a mobile app could do that and then transfer the data. We've got a web-based BP averaging calculator that can be used, and I think worst case is that somebody has to pull out a calculator and do the math. That is a high-risk situation because of the risk of making mistakes. And then the actionable BP is the average systolic and diastolic blood pressure. Let's go to the next slide. So very briefly, next slide. I want to talk about quality measures, and then we'll get to Q&A, because I think there are always a lot of questions around this. I'll just say that in 2019, the only quality measure that allowed SMVP, or home blood pressures, to be used in the numerator for controlling high blood pressure quality measures was HEDIS. That goes back to 2017, when they first allowed home blood pressures to be used if they were digitally stored and transmitted. In 2020, all of the listed, all 5 of the main hypertension control blood pressure measures started allowing SMVP. Again, in general, if they are digitally stored and transmitted to the provider, or used a remote monitoring device, which we can talk about in detail. Again, that's typically where a Bluetooth-enabled device transmits blood pressures to a mobile app that then communicates those results either to the EHR or to the provider in a secure messaging format, or to a cloud-based system that's secure, where a provider could log on and see those results. So what changed in the middle of 2020? So in 2020, all 5 started accepting SMVP, which is fantastic. And then HEDIS went to the next level and said, we're now going to accept patient-reported blood pressures, meaning we're going to get rid of the requirement that these blood pressures must be digitally stored and transmitted. And shortly that happened July 1st this year. And just last month, MIPS 236 and CMS signaled that they were now, because of COVID-19, going to allow patient-reported blood pressures as well. I know for this audience, the UDS measure is of prime importance here. That is still requiring a remote monitoring device to be used so that blood pressures can be digitally stored and transmitted. And we can talk about what that means, but when we talk to HRSA about the UDS quality measure, and you may or may not be aware of this, but that requirement to digitally store and transmit does include both synchronous video visits, where a device is held up and shown to the provider directly on screen, where you can see a blood pressure and a date, or asynchronous communication of that blood pressure monitor result, the most recent. A photo can be taken of that blood pressure and then securely messaged to the provider, and also be documented in the medical record and used towards that UDS measure. So that is, we have that confirmed from HRSA in writing, that both synchronous and asynchronous transmission, which can be video or transmitted by SMS or secure email with a photo image of the device, does count towards numerator compliance. So I'm at time there, and I just want to make sure we have plenty of time for Q&A. So if you can either go to the next slide or open up the Q&A session, that would be great. We'd love to get to your questions. Please don't hesitate to ask questions, put them in the chat so that we can have a good discussion moving forward.
Great, and Mike, thank you so much for that. I think we're going to start off with maybe just a couple more polling questions. And so then we're going to go directly into the Q&A to also allow people some time to put additional questions in the chat. We do have a few, but we'd love to hear more. So I'm going to send this back over to Stephanie just to walk us through the polling again before we introduce a couple more polling questions.
Sure thing, Nita. Good afternoon, everyone. So we just have here up on the screen the live polling instructions for everyone to participate in the polling for today's session. If you haven't had the opportunity already earlier during today's webinar, please take out your mobile phone and send a text message to the number 22333 with the message in the box being COVID-19 Heroes. So once you send that message in the box to the number 22333, you should receive a response message confirming you have joined today's session. Once you have joined today's session, you are able to participate in the polls for today. So if you did this earlier, you should be all set. If not, I'll just give it a couple more seconds just for folks to get into the message room for the polling before we move to the next set of polls. All right.
Wonderful, and thank you again, Stephanie. So the next question that we have to the group is, are blood pressure values shared between patients and their care teams from devices during telehealth? We'd love to hear what's happening at your health centers. Give folks a minute or so to respond. Wonderful. Looks like there's a couple responses still coming in. We're going to just keep it up for a couple more seconds. Wonderful. So it looks like the vast majority of folks are having blood pressure values shared between patients and their care teams during telehealth. All right, let's go on to the next question, which is what blood pressure measurement tools are currently in use by your patients?
So for this poll question, it is open-ended, so feel free to submit a message of the tool or tools that you're currently using with your patients.
Great, we see some responses coming in. And if you all have any specific brands or that you're using, that's also very helpful. Thank you. Perfect. Super. Thank you all so much for everyone who's responded. That's very helpful. All right, well, we really appreciate all the participation in these polling questions. And we're going to advance now to some very specific questions that have been posed in the chat. I want to start off this section by thanking our presenters once again, Dr. Reynolds, Dr. Sachdev, and Ms. Murakami, for all the great information. The first question that we have is as it pertains to blood pressure measurement. And the question is, when you say it is optimally done for 7 days, is that with a new diagnosis of hypertension or when a new medication is given?
So this is Mike. So that's for both. Anytime you want to assess someone's blood pressure control, it should be optimally, it would be done for a 7-day period. So if yes, it is used to confirm a suspected diagnosis of sustained hypertension or white coat or masked hypertension, but it is also used at least 2 weeks after a medication change to assess control, or a week prior to a follow-up encounter, whether it's a virtual or in-person encounter, to assess blood pressure control if you're checking somebody typically like you would do in the office. If they're controlled, maybe once or twice a year. If they're uncontrolled, you may see them back once a month. You would do this for 1 week prior to that visit. So same protocol. Of note is that once somebody attains control, the recommendation is a little bit less evidence-based, but to have somebody a little bit more casually mention their blood pressure at least once a week to maintain engagement is recommended, even after they've achieved control, just to keep them used to self-monitoring and to make sure that nothing is starting to go in the wrong direction.
Thank you very much, Mike. The next question is, can you confirm the capture of HEDIS codes? I know it pulls data from patient diagnosis history, but do we need to drop the F code under the corresponding diagnosis code? Or can the F code fall under any diagnosis code for credit?
Yeah, this is Mike again. I'm not sure I can answer that question relating to coding for tying a blood pressure specifically to, for the HEDIS blood pressure control measure. What I can say is the advice that we've been given from NCQA specifically about HEDIS, opening that up to be patient reported now, is that means, according to HEDIS, again, this is what they relayed, that you could literally write the blood pressure that you is reported in a phone call from a patient into the vital signs field, and that should count towards the quality measure. So again, I can't speak to the coding, which may be related to electronic submission, but I can tell you that if the blood pressure from home is in the vitals field, it should count towards the numerator of the HEDIS measure as it's written now for the next 2 years through 2020 and 2021, if that helps. If you need a follow-up clarifying question, please go ahead and ask.
All right, we'll see if a follow-up question comes in here. We're going to, meanwhile, move on to another question, which is requesting confirmation. Just to confirm, HRSA has stated that video visits where BP measurement are held up and shown to the clinician, or photos of the most recent BPs that are securely messaged will meet UDS requirements. Is this correct?
Yes. Yeah, so I don't know if you're, so I mean, I could go into more detail, but the simple answer is yes, and it's great news that they've confirmed that in writing and verbally through communication.
Great, thank you, Mike. And another question is, can you share the document from HRSA, the HRSA notice for synchronous and asynchronous reporting of blood pressure?
What I can do is share the link to that publicly available conversation that exists on the HRSA support website. So yes, we can make sure we get that link sent out.
All right, another question. Is the secure message containing the patient's BP used for proof or backup, and the vital sign is what is pulled for the data?
So one of the things, so the vital sign typically, it depends how you submit for your UDS, but typically the data comes from vital signs. But what's very important that I haven't mentioned to this point is that you make very clear in your documentation how the blood pressure was obtained. So if it was obtained through a photo, if it was obtained through somebody holding up a blood pressure measurement device during a synchronous encounter, that needs to be documented into the medical record somewhere. And this is primarily in case an audit occurs. You want to be able to explain where the blood pressure measurement came from, because you may or may not have it tied to an encounter, but you want to be very clear that a blood pressure measurement device with memory storage and a dating function, a timestamp or date was used, that it was communicated synchronously through a telehealth encounter, and that blood pressure was documented, on this date into the medical record. So while you could just put the blood pressure measurement into the vital sign, you really want to have some support documentation to make it very clear where that came from, and what it's being used for. And I'll say one more thing, because I think this is really important. The home blood pressures, we're talking about using a week of home blood pressures to assess control, to make a diagnosis and titrate treatment, to take clinical action based on a week of blood pressures averaged. Unfortunately, the UDS measure is using a single blood pressure to score quality. This is true of most quality measures. A single blood pressure measurement, and it's using 140/90 as the threshold for compliance for being controlled, which is not the case for out of office, which is typically 135/85 or lower. So I just want to make that point. It may have been made, but I just want to reiterate it, that even though you will score as being compliant if a blood pressure is less than 140/90 from home, organ damage at home, hypertension mediated target organ damage occurs starting at 135/85 from home blood pressures. So you need to be mindful of that, and you can know that if it's 139/89, you may be scored as being in compliance with the measure and get a better score, but that patient is still at risk for having uncontrolled high blood pressure.
And this is Linda. We have those interpretation tables that I mentioned on that website to help you guys understand a little more what Mike's talking about.
Right. The next question is, if a blood pressure measurement is taken during a televisit, so for a health maintenance visit, is the vital sign that needs to be displayed for a week of measurements or for that day?
Yeah, that's a really good question. And honestly, from a vital sign perspective, there's not a lot of guidance on that, but I would look at a vital sign from a single home blood pressure to be the same as a single blood pressure in an office setting. It gives you some information, but it's not something that you would want to make a diagnosis based on. Remember, in-office blood pressures, guideline recommendations are, even to assess control for anyone, is to use 2 or more blood pressures averaged on 2 or more encounters. So a single blood pressure in the office gives you a vital sign, but that doesn't necessarily mean you take clinical action on it, and it's the same at home. A single blood pressure with a home monitor is not the same thing, it's not really actionable. Even if it can be scored in a quality measure, it is not actionable to titrate treatment. So you need to be cautious there. I would just look at a single blood pressure taken during a home visit by a patient to be akin to a vital sign of a single blood pressure in the office setting. And that, I'll just leave it at that. It's not something that you would use to make a diagnosis or assess control. But it could signal, if it was high, for example, that you need to follow up with a week of blood pressures to more accurately assess control.
Great, thank you. The next question is, do providers need to put in an order for SMVP?
Yeah, this is Neha. I can start, and then Mike and Linda, please feel free to add. So in terms of, I think just to separate this a little, a patient does need to be recommended for SMVP, and we've already discussed the indications for that. And that is usually done by a provider, although in some cases it can be done by other team members. But in terms of a specific EHR order or additional way of tracking these patients, you do want that. You want to be able to follow up with patients, although being able to actually place an order in the electronic health record depends on your availability and what your technology is capable of. But I think more importantly, somebody does need to assess a patient and determine the evidence-based protocol to be used for SMVP and the indication, as well as when the results should be received back. And Mike, Linda, please feel free to add to that.
Yeah, no, I agree.
All right, thank you, Neha. So the next question is, how does this all compare to 24-hour ambulatory blood pressure monitoring? What if the values or averages don't correspond?
Well, I could start this one and then turn it over to anyone else who wants to jump in. So, 24-hour ambulatory monitoring and SMVP are not the same. They're not equivalent, and they don't have the same amount of reproducibility. I'll say that SMVP over a week of period of time is the most reproducible form of blood pressure measurement. So that if you took the first week of January, a week of home blood pressures, and then the first week of February, a week of home blood pressures with no intervention in between, they're more likely to be the same or close to correlate extremely well with each other than if you did the same thing with the 24-hour ABPM. 24-hour ambulatory monitoring has a lot of evidence to say that it is the most accurate predictor of future cardiovascular risk. And of course, it's unique in that it measures asleep blood pressures. However, it has not been shown to be superior to SMVP, or SMVP has not been shown to be superior to ABPM when you compare them both together. So they measure different things in some ways, but the daytime mean from a 24-hour ambulatory monitor correlates very well with the daytime a week of home blood pressures. So that's something, but you can't really compare them. Both forms of out-of-office measurement are acceptable. And the only reason that 24-hour ABPM tends to be the reference standard is that there's more RCT, randomized controlled trial evidence for that, not necessarily that it's superior. There's just more of it, so it got the nod from the USPSTF systematic review to be the most reliable and the reference standard. But again, there really isn't evidence to say that it's superior for how it is being used in clinical practice, other than it does give you information during sleep, which is very important. Home blood pressure monitors now, they're starting to create them that can record blood pressures overnight intermittently, and realize that for most people who get 24-hour ambulatory monitoring, the monitor is only going off every 30 to 60 minutes during sleep, typically 60 minutes. So it's not that many measurements, but it is an important factor. Should be reproducible though with home blood pressure monitoring when they start to put timers in, which is starting now.
Yeah, so this is Linda, and I just wanted to say, sorry, Nia, that
no, go ahead.
when we talk about using either one, then because the way the guidelines read and the way Mike explains it to us, that's why we talk about using SMVP, because it is more convenient and more accessible to people. We were working with a practice in northern Illinois, southern Wisconsin, actually a health system, and one of the parts of Illinois where this clinic was, they couldn't find 24-hour ABPM for like 50 miles around them. So like there's nobody had it. And so that's why, so many people rely on the SMVP values. Go ahead, sorry, Neha.
No, you said what I was going to say, which is that SMVP is probably more pragmatic and practical to use in outpatient primary care. And that, even though it's ABPM and SMVP are both options, they're complementary. SMVP, just for the reasons Linda described and Mike explained, tends to be used more often by primary care physicians.
Great, thank you so much, Linda, Mike, and Neha. The next question is, can you share any updates related to reimbursement for home monitoring devices?
I'm sorry, did you say recommendations for home monitoring devices?
Any updates regarding reimbursement for that's right.
Yes, I gotcha. Okay, no, I just missed the reimbursement part. So what I can tell you is that at the AMA, we're advocating very hard to try to figure out ways for more coverage. We're working, private payers are starting to pay more. And I think the big one is going to be CMS. If we can get CMS to do a non-coverage determination to decide whether or not to cover home blood pressure monitoring. And I can tell you that we're working towards that as quickly as we can and have been since the public health emergency from the pandemic went into effect. And I'm optimistic that we should see more coverage of devices It's hard to say when. Probably, fingers crossed it'll happen within the next year and preferably within the next few months, but we have no way to know when this could happen. It's unlikely to occur before next year, but we're working, again, very hard on this with the American Heart Association and many other organizations. And I do think as we see, payers like Aetna starting to pay for more devices and more federal employee programs, we're starting to see it, and for obvious reasons, because of the pandemic, we need to have device coverage, and that's where we're coming from, that this is really becoming urgent or emergent. We have to be able to manage hypertension remotely. In order to do that effectively, we need home blood pressure monitors to be in the hands of everyone with a diagnosis of hypertension, and even those suspected of having hypertension. So hopefully that's coming. I do think that it will likely come for those with an existing diagnosis of hypertension before ruling out hypertension, but hopefully we can get to both eventually. But I think any step in that direction would be a big one, and I think it's coming. So I'm optimistic, working very hard on that with our teams, the whole AMA, the whole AHA, advocating hard. So fingers crossed it'll happen soon.
Wonderful, and thank you all so much for that advocacy. The last question that we have is just confirming that with what you have shared about the quality measures and what is allowable now, that EMR integration is not a requirement to count home blood pressure monitoring for UDS measures.
Yeah, it's definitely not a requirement, but the documentation should occur to explain how the measurement got into the EHR, if that makes sense. But automated integration is not a requirement.
So Mike, can you explain a little bit about what that documentation might look like?
Sure. So if for example, I'm having a telehealth visit with a patient and they report that they hold up their device and they say, I took a week of home blood pressures and here's the most recent, or they just literally hold up their device. Technically for the UDS measure, they can say, here's my most recent blood pressure. If there's a date on that screen and it's a, what's considered to be a remote monitoring device, which is a Bluetooth enabled monitor or a device that's able to digitally store readings, they hold that up and I see that, I would just need to document that exactly what happened and that you obtained that reading transmitted through video from the patient. And if that was transmitted via SMS or via secure email, same thing. I would just need to document that I reviewed the blood pressure readings directly from the device by viewing a photo that was sent to me securely, by the patient. And then you can document that blood pressure in the vitals field. But I think it's really important to make sure that you are documenting the process of how you obtain that blood pressure, and then you should be set. And that's right from HRSA.
Perfect. Thank you so much, Mike. I just want to make sure to call everyone's attention to all the links that have been shared in the chat. We also received a question on if we would be able to make these links available later, and we certainly will. Those links include the SMVP quick guide that Linda mentioned, as well as the list of validated blood pressure machines, as well as the ONC response from HRSA related to home blood pressure monitoring and what counts for UDS. So those will be made available. With that, I really want to thank once again our wonderful speakers for all of their guidance. And I want to thank all of you for joining us. We really appreciate your time. And I also really want to extend thanks to the PTech and QTech teams for their work in planning this session. Please do look out for the recording and the message around links. And we want to extend our best wishes that everyone stays in good health and spirits. Thank you so much.